Semua ada dah? Oh, ada lagi tak? Habis dah punya. Ha?
Ada. Semua ada.
Oh, cushion. Okay, I remember this my third session hari ni. Oh, session ketiga. Itu session ketiga. I dah dizzy ni. Dah cukup, semua sedia dah? Siti Aisyah mana? Siapa nak present?
I start first, Doctor?
Ha?
Can I start first?
Siapa?
I'm Nur Anis.
Mana?
Uh,
Mana Noranis? Kat mana Noranis? Oh. Siti Aisyah. Siapa Siti Aisyah? Ada siapa Siti Aisyah ni? Dalam ni? Ada ke you punya ni? Blog you Siti Aisyah?
Ada.
Ada?
Ada, Doktor.
Dia masuk tengah kan kena soal ke soalan jawab. Okey, present dulu, siapa present tadi? Present. Okey, present. Start lah. Siapa present dulu tadi?
sorry, Doctor, I termute. Sorry, I termute.
Termute. Oh, okay. Present boleh.
Sorry. So, Amiruddin, a 2-year, 5-month-old Malay boy, presented to the emergency department of hospital Tunku Afwan Afzan due to episode of vomiting and loose stool for 3 days. So, for the history of presenting illness, the history was taken from the father. According to the father, the patient was apparently well until 3 days prior to admission when he started to have several episodes of vomiting. So the vomiting was non-projectile, occurred 10 times on the first day, 7 times on the second, and 1 time on the day of admissions. And usually it occurred following meals. So the volume was about half a cup per vomiting, and the vomitus consists of mainly food particles on the first day, and later consists of milk and clear water, as he did not eat any food since the first day of illness. However, there is no blood, mucus, or greenish vomit. So the vomiting persisted throughout these 3 days, but there are changes in frequency of vomiting, which decreases by day. So the father also noticed that 3 days prior to admission, the patient developed loose stool, and it was watery and yellowish brown in color. There was increase in frequency, which is about 10 times on the first day, 7 times on the second, and 4 to 5 times on the day of admission. And his normal bowel habit was twice per day, which consists of semi-solid stool. His father also noticed that the volume was more than usual, but he was unable to exactly quantify the volumes. And the father noticed that there were overflowing of feces from the diapers during the first episode. However, there is no blood, mucus, or foul smelling presence in the stool. Otherwise, there is no symptom to suggest parenteral diarrhea, such as ear discharge, dysuria, hematuria, rapid breathing, or chesty cough. Apart from that, the patient also developed fever 3 days prior to admissions when his father noticed that he was warm to touch. The fever was sudden in onset and was characterized with chills and rigor. There was no temperature measured at home. However, the father claimed that it was 38 degrees Celsius when he sought treatment at Clinic Putra on his first day of illness. He was given rectal antibiotic, but the fever only resolved temporarily. Otherwise, the father did not notice any specific pattern for the fever, no rash, no fitting episode, or neck stiffness. He also denied living in the dengue prone area, doing any activities in river or jungle trekking together with his son. And in addition, he also had generalized abdominal pain for 2 days prior to admission. The pain was intermittent in nature. However, he cannot describe exactly the character of the pain. He can still ambulate well. The onset of the abdominal pain was sudden and not related to meals consumption. There is no aggravating factor, but usually it was relieved with ointment. And the patient cannot sleep well at night and always crying. So he had no history of taking outside food prior to the onset of fever and no family member with the same symptom. And due to the illness, he also had reduced oral intake and only consumed plain water and less amount of formula milk. Since then, the father noticed that he was becoming less active and spent more time laying down. He was unsure of the exact frequency and amount of urine. Otherwise, there was no increase in flat tests or no history of sick contact. So, upon further questioning, the father claimed that he had dry lips and sunken eye, but drinks normally throughout the day since the onset of symptom. And also, father claimed that there was still tears when the patient cried. The father also claimed that the patient has loss of weight from 13 kilogram to 11 kilogram. The father was worried and decided to bring his son to Clinic Putra on the first day of illness and was given parenteral antibiotic drug and was discharged. However, the effect was temporary, and the father brought his son to the clinic kesihatan on the second day and was referred to the emergency department of HTAA. So that's all for HLPI.
Hmm.
For
Siapa
the
lagi? Siapa lagi present soalan lagi? Hmm?
Saya, Doktor.
Mana? Send.
My patient is Amni, 6-year-old Malay girl with underlying steroid-resistant nephrotic syndrome, was referred from Hospital Muazzam to emergency department of HTAE with complaint of worsening generalized body swelling for 4 days duration. For the HOPI, history was obtained from her biological mother. So she was apparently well until 4 days prior to the admission. She suddenly started to have facial puffiness and periorbital swelling. The next day, she had swelling all over her body, included her genitalia part. So the swelling was progressive and worse in the morning. It was not associated with tenderness, itchiness, or redness. Besides, her mother also noticed her abdomen was slightly distended and she had gained some weight, but her mother was unsure the actual amount she gained. And she also claimed that her child can still ambulate by herself despite of swelling of the lower limb.
This child apa?
Her mother claimed that her child can still ambulate by herself despite swelling of the lower limb. So she was not known to have any allergies towards food or any medications, and there were no history of insect bites or trauma. Her mother also claimed that she had reduced urine outputs and presence of faulty urine. Usually, she will urinate about 6 to 7 times per day. However, on the day of admission, she only urinates about 2 times. The urine was concentrated, which was described as dark yellow in color. However, there was no complaint of pain during micturition, no hematuria or incontinence. Her bowel habit is also normal. Furthermore, she also had history of fever 2 days prior to the admission. It is a low-grade fever with documented temperature of 38.3 at night and 38.8 on the next morning. So the fever was continuous and not associated with chills or rigor. She was given syrup paracetamol 3 times per day and it had helped to relieve the fever. So the fever was associated with cough, which is described as chesty in nature and is non-productive. She also had runny nose with clear nasal discharge. However, she did not complain any sore throat or loss of appetite. So there was no sick contact at home. However, her mother did not sure about any sick contact in the school. Otherwise, there were no history of shortness of breath, rapid breathing, orthopnea, paroxysmal nocturnal dyspnea. Mother also denied any nausea, vomiting, abdominal pain, or diarrhea. There were also no history of yellowish discoloration of the skin or eye and any bleeding tendencies such as epistaxis or bruises. Mother also claimed she looked lethargic and not very active during the episodes of swelling. Upon further questioning, this was not the first time she experienced these symptoms. She had been frequently admitted to the hospital due to similar problems since 2015, where she was being diagnosed with nephrotic syndrome when she is 2 years old. At that time, she also presented with progressive swelling of her body. The urine dipstick test at that time was 4+, and blood test showed low serum albumin level with high albumin level in the urine test. And the further investigations were suggestive of the nephrotic syndrome, and her parents were concerned about the disease and the treatment. So since then, she had been diagnosed with steroid-dependent nephrotic syndrome and had multiple admissions afterwards due to the frequent relapse. Her first episode of relapse was in June 2015. Her mother told that generally she was being hospitalized about 8 times every year for these past 3 years. She was given prednisolone as initial treatment and her symptoms resolved. However, after a few episodes of relapse, she developed resistance towards steroid and was given cyclophosphamide instead. So according to the mother, she was diagnosed with steroid-resistant nephrotic syndrome in 2016, in which renal biopsy had been done with results showing minimal change disease. Her mother claimed that on January 2019, she was told to off the cyclosporine and amiodarone when her mother claimed that she had frequent episodes of vomiting. And also recently, she had stopped taking prednisolone on January 2019. That's all from the history of presenting illness.
So, Aina, apa different first case, second case?
In my opinion, the second case is more severe than the first case.
The difference, I ask you which one more severe.
Mm,
I ask you the severe, I said the difference only.
differences dari segi management.
Differences of the case.
Oh, differential ke differences?
Differences between first case and second case.
Hmm. Kalau nephrotic tu macam perlu long term punya observation.
Susah sangat. You listen to the case. Aliana, what differences?
The first case is acute and second case is acute on chronic condition.
Pardon?
Doctor, can you hear me? Okay. So the first one is acute condition. Meanwhile, The second case is acute on chronic disease.
It's chronic disease. Enak, apa susah sangat? What different first case, second case?
Acute dengan chronic.
Ada lagi? Apa different lagi? Akilah?
No. So for the first case, it's more like the system involved is gastrointestinal. Patient came with vomiting, loose stool, and fever. While second case is maybe like from renal due to generalized body swelling.
Apa susah enak ha? Try again.
Dari segi history dia berbeza.
Apa beza dia?
Macam tadi first case tu macam datang dengan vomiting episode, fever, abdominal pain. This one datang dengan generalized body swelling.
Haikal, apa beza dia?
Beza between two case ke ada? I think probably the complication develop.
You dah dengar listen tadi kan, this history kan. Based on the history, apa beza dia?
Different between those cases ke apa?
Yeah, between the two cases.
Selain itu. For the second case, we need to correlate with the previous medical cause.
You don't understand the case. Hana, apa beza dia?
Hello. Okay. Since the first case is pointing towards acute gastroenteritis. So,
tak dengar.
Since the hello, doktor dengar? Hello. Okay. So the first case is pointing towards acute gastroenteritis.
I don't ask you listen to the story. You listen apa different dia first case second case.
The first case.
Macam pematian you all ni. Age dah different dah. Age sama.
Age tak sama. The second case is 6 years old. The first case is
apa yang kenapa kumpulan ni speed sikit daripada kumpulan yang lain? Kumpulan lain semua dapat simple, cepat tak like that. This one lagi dari case lagi simple case, you tahu tak? So many difference. Haikal, apa different lagi? Amirul?
For the first case is fresh case, but for the second case is the patient with known underlying causes.
Macam mana tadi dah kau discuss kan, chronic ni acute. You dengar the history kan. Siti Noor ada Wiyah?
Like in the first case, the patient have loss of weight due to the vomiting and diarrhea. And in the second case, since the patient has swelling, she have increase in weight.
Siti Aisyah? You pun tak tajam, you punya perhatian you all. Apa beza?
Besides that, first case, there is no URTI symptoms. And in the second case, there is URTI symptoms.
Nuranis? Tak tajam lalu perhatian.
The first case has haven't received any treatment, but the
Ah.
second case always have received treatment before.
Treatment apa? Penicillin.
Steroid.
Muslihana.
The first case is the chief complaint is loose stool and vomiting, while the second case is
Your colleague dah mention dah tadi.
I'm not sure.
Not sure. The first case ada ada sunken eyes. Second case tak ada sunken eyes. Oh, susah sangat. No, it show me you're tak sharp. That's all. Pemerhatian you tak sharp. You tak sharp tau, tak sharp. You cannot see the difference between the things. Even small things pun tak dapat bezakan difference. Age tak boleh difference kan. Banyak lagi the things you can look the difference. It telling me the sharpness of your thought process. Tengok benda tu. You tengok benda superficial saja. You tengok sekali lalu you tengok dalam ward pun dia tahu so many difference case tu depan mata you. Tapi bila kita ask you, can you identify the difference? Tak boleh. Very weak observation. Weak lah, observation weak. I can list 30, 40 list different in this case. In the first two group tu, case tak banyak different tau. Tapi they able to point it out. Your group tak boleh nak pointed case yang very obvious the difference. Haikal, cuba lagi.
For the first case, there is no faulty urine. For the second case, there is faulty urine. And then the other thing, second case, the patient is already on several medication treatments.
Now you mention dah. Hana?
For the first case, there is massive fluid loss. For the second case, the fluid is retained. There is fluid retention.
Tension. Okay, you on that. Muslihana?
The first case, we have dehydration symptoms such as dry lips, while the second case, it's different presentation, which is body swelling.
Your friend have mentioned dah tadi. Aina, how many percent they had the first case? You think mild, moderate, or severe?
Moderate.
Why you say moderate?
Because he has sunken eyes.
Tapi they got tears. Still got tears.
He has reduced oral intake.
The reduced intake is assessment of dehydration. How you assess dehydration status? Hydration status.
We assess the from the hip to the.
Tell me how you assess hydration status. Tell me how you assess hydration status.
So first I will observe the patient, the general appearance of the patient. So and then I will look at his eyes.
You tell me how you do assessment, then tell me what is mild, what is moderate, what is severe. And give me your conclusion.
So I will look at the, I will assess his general condition. If it is mild, he is well alert. If it is moderate, he is in restless or irritable state. If it is severe, he is in lethargic or unconscious state.
Lagi?
And then I will look at his sunken eyes. If mild, there's no sunken eyes. If moderate, he has sunken eyes. If moderate and severe, got sunken eyes. And then I will look at I will assess, I will offer the child's the fluid. If he can drink normally, then he has mild hydration. If he drink eagerly, means he is in moderate state. If he cannot drink at all, he not able to drink, then he is in severe state. And then I will pinch his skin. If the skin goes back immediately, then it is mild. If it goes back slowly, then it's moderate. If it goes very, very slowly, which is more than 2 seconds, then it's severe.
Itu je.
And then tears. For the tears mild, he will cry. This person will cry. If moderate, then he has maybe weak cry. If severe, then he does not cry at all. There's no cry.
Does not cry. We cry. Dari mana nak belajar tu? Cry tu.
I mean, tak ada tears, tak nampak tears tu. Tak
Tears
nampak tears tu. Absent of tears in severe dehydration.
Moderate, absent, tak absent?
Moderate, absent. Absent.
Mild?
Mild, there's a presence of tears.
Lagi? Apa lagi?
Skin color.
Sekali dah mention dah. Skin tegar. Apa lagi? Anybody want to add?
We can look at the patient vital sign to know the severity. For heart rate, for normal, usually, and for mild, usually normal. For moderate, tachycardia. For severe, maybe bradycardia. And also for the respiratory rate, same. In mild, normal, moderate, tachypnea. In severe, reduce. And for blood pressure, in mild, normal, in moderate, increase. In severe, hypotensive.
Mucus
assessment of
mucus membrane. Mucosa.
For mucous membrane, in mild, normal, moist. In moderate, sticky. And in severe, dry. We can assess the urine output as well. For urine output, in mild, normal. For moderate, reduce. For severe, maybe no urine at all.
So Aliana.
Lastly,
cukup lah tu. Aliana, what you think? Mild, moderate or severe?
For me, it's moderate because the patient has sunken eyes and also reduced urine output.
Ya, Nurul. Nurul. Siapa present tadi? Siti ya? Siapa present tadi?
Anis.
Mana ni Nurul Nurul Anis. Ada betul ke dia cakap?
Yes, it is moderately dehydrated.
Lagi? But the child didn't take orally kan? Decrease oral intake kan?
The child has decreased oral intake but still can drink.
Then why
normally.
You say moderate when you say decrease oral intake? But the child got, you kata the child apa lagi? The child have tears, is it? Then why moderate? Got tears still can be mild. Apa lagi indikator? Mucous membrane?
Weight loss.
Ada weight loss?
Patient lethargy.
Lethargy. Weight loss ada?
Yes, weight loss 2 kilogram.
Lost weight.
Presenter mentioned lost weight.
Yalah. Nurul lah, how much they lost weight?
According to the father, he claimed that the child lost weight 2 kilogram.
2 kilogram. Dalam mission. Berat sebelum lahir, berat sebelum berat masuk ward berapa?
At ward 11.5.
Sebelum tu berat dia?
13.
So what you think, Alana? Mild, moderate or severe?
I still think it's moderate.
15 still moderate. 2 kilo out of the 13, how many percent was that?
11.5.
Why you say it's moderate?
Because I think majority of the symptom is moderate symptom.
This is lethargy. Is it? Lethargy, the child lethargy, reduce your intake, lost 10% weight. How you say it's moderate? Lost 10% of the weight. Tell me why this child lost weight.
He has a poor oral intake, and also because of the symptoms vomiting and diarrhea.
Then, so the lost weight, lost muscle ke, lost fluid ke, lost apa? Why lost weight?
Lost fluid.
Then can you explain why the child lethargy?
Why lethargy? Because he wasn't getting enough nutrition for the energy production.
So he doesn't have enough drink. So kalau you puasa pun you lethargy walaupun you tak dehydrated. Yeah. If you didn't enough nutrition macam belum puasa tu, you feel lethargy also, is it? You don't think lethargy is because of dehydration? Rather than you think lethargy because of not enough nutrition. So why the child become lethargy in your opinion? Nurul Akilah.
Because of dehydration.
Mild, moderate or severe?
I think it's moderate.
Why you say it's moderate when you calculate the child losing 10% of body weight?
Because it 5 to
moderate
10%.
is how many percent?
5 to 10%.
Mana ada 5 to 10%? Moderate is how many percent? Moderate is 5%. Severe is how many percent?
10%.
10%. So the child is mild, moderate or severe?
Be severe, but no, moderate, because for the general he's still conscious.
lethargy conscious, lethargy, alert tu lethargy.
From the history, the patient came alert. Lethargic.
Lethargy, alert. Nurul lah, the patient macam mana on admission?
On admission, the patient is less active, appear lethargic, vomiting and diarrhea with fever.
On admission, I mean lethargic, less active, sunken eyes, skin dry tak tahu.
The mucus is dry, but the parents mentioned that the child is restless at night. It's not totally lethargic.
Not restless, not totally lethargic. Lepas tu, skin tegar dia?
Skin tegar is normal.
Skin tegar is normal. Eye sunken, skin tegar is normal. Mucosa dia?
Mucus is a bit dry, but not extensive.
A bit dry, tapi sunken eyes.
Sunken is only mild sunken.
Mild sunken, tapi lost 10 kilo. Lost 10%.
That is claimed by the father.
You don't trust the father. The father is bluffing. Not true. Which one you believe? Objective measurement or non-objective measurement? Which one is objective measurement here?
The weight taken at admission? The weight taken at admission.
Which one is more objective measurement? One of it is wrong. Either the daughter assessment is wrong or the weight taken is wrong. Which one? You cannot have 10% dehydration with this sign and symptom. Dysentery. You know 10% dehydration, how is it? So they see it doesn't tally between 10% dehydration and the sign and symptom. So which one is wrong, you think? Is the father is wrong, or the give a wrong weight, or the doctor is wrong, wrongly assess the patient? Which one? Haikal, what your opinion?
I think the doctor impression is more accurate
than the weight.
Yes, probably the father terlupa.
Wrongly give weight.
Yes.
The mother give the weight is more accurate than father. What happened is the one who gave the weight is the mother. Which one you going to believe?
Usually female will be more particular.
Female will be more particular. You accept that?
Usually,
except you lah. You mean exception is you.
No.
That's all. Usually the male doesn't give that particular. But imagine the father can remember the weight previously. How many father can remember the weight of their children? Ask you. A father who can remember the weight of their child is exceptional. Can tell you it's exceptional. This father can remember the weight of his child. How many father can remember the weight of his child? I ask you, go and you can make study. Probably 5% only can remember the weight of his child. 5% to 3%. Mother probably 50-60%. So this father can remember the weight of his child. Special already. You know, it's exceptional already. You still don't believe the father. Because by standard, the father will say dia tak ingat punya. But this father remember. We can tell 13 what berat dia? 13? Berapa dia tahu?
11.5.
Ha?
11.5.
Ha. Point something lalu. Oh, the father
11.5 at admission, but the patient said 11.
Eh?
The patient said 11.
11 lah. Kalau remember point-point lagi dahsyat. Dia tak boleh ingat point. Oh. Budak tu pakai pampers lagi?
Currently, yes.
Tak boleh nak imagine. Probably weight chart, different weight scale. Probably dia pakai berat kat sana, pakai pampers, this one pampers tu kena dia tu. They properly take the weight scale, probably hospital take the weight scale better, proper compared to sana mungkin pakai pampers, mungkin pakai baju lagi tebal lagi tu, ini mungkin dibogilkan. Tak boleh nak imagine all those things. Cuma you all take for granted the weight was done properly or not properly. Tak tahu. I have more the father is correct. Because it's not easy to father can remember the weight. But I am more to the technique of taking weight. How they did it in where 11 kilo kat mana dia ambil? Muazzam sini. Kat mana? Tak tahu.
For the 11.5, it was at admission at HTAA, but the father said 11. I don't know where the 11 come from.
You don't know where is it? Kat mana dia ambil? Mungkin dekat GP ke, dekat mana ke? And then usually pampers mungkin dah penuh lepas dia ambil. You don't know.
I'm not sure.
Hospital, they have a certain standard before you take. Send father tu kan. Nobody trust. Imagine the future father doesn't trust the father. The future father doesn't trust the own kind. So, Anna, what you think about this? You think which one more severe? The first case or second case? Anna?
Personally, I think the first case.
Why?
Because the first case, this patient can go into hypovolemic shock because of the dehydration, the fluid
The second
loss.
case cannot.
The second case, it can also, because hypovolemia is also a complication of pneumatic.
The second case, they already developed hypovolemic symptom.
Sorry, Doctor, can you repeat the question?
What is the sign, the symptom from the history that told you that the second case already developed hypovolemic?
Okay, so the patient has no abdominal pain because in hypovolemia, patient can come with abdominal pain.
Ya ke? Indifrotic.
This because sebab in
dengue, you know. This nephrotic syndrome, common distended because of the fluid. You mentioned just now is a dengue.
Also in hypovolemia, patient can come with cold peripheries, hypotension.
History just now is the history. What is in the history that tell you that patient is already in the state start to have hypovolemia?
Patient has decreased urine output.
Patient already decreased urine output. Don't you not worry about that?
Yes, we are worried about that.
Ah. And then from the history of the first case, you are not in the first case mild, moderate, or severe.
Since the weight loss is 10%,
You trust the 10% though. You don't think it's wrong in measurement by the place they do it. You don't believe that. Because the 10% didn't tell you with clinical symptom by the doctor, by the written by your colleague, not doctor yet. Written by your colleague. Your colleague is the final year medical student, bukan doktor tu, final year medical student.
I trust the clinical symptoms more than the.
But you see, the one who assess is your student or your final year student, bukan doktor. Mungkin dia doktor, mungkin dah pass lah, dia dah hosmer, baru lepas dia dah hosmer. So you think in all this particular, all this, do you think which one more you believe? You think the first case, second case more severe? The second case already has symptom of hypovolemic lah.
Yeah, I think the second case.
But the first case lethargy, restless. Amiro, you have Amiro. Look, you think about this both case. You think which one worry you more?
I will worry more on the first case because the patient is actively on the symptom, which is vomiting also diarrhea.
Actively, maksud still vomiting and diarrhea. You mean still got ongoing loss. You mean the second case that the ongoing hypovolemic? You mean that the albumin dia the 20 tak drop dari 16, tak drop dari 14 over the time? I mean kat 16 continuously 16 2-3 hari. Edema dia getting severe and severe. Progressive edema. It means that the albumin keep on dropping and dropping. I mean, this child also progressively hypovolemic. Is there any other factor you worried about? About the first case? Why you worry more on the first case rather than second case?
How about the age, doctor? The first case.
The age. This child is how old?
2 years old.
Younger, young. Not that young lah. But younger. The other thing? Siti? Siti, what do you think?
Maybe because we worried more on the first case because she has reduced of the oral intake, while in the second case, the patient can still tolerate to take
because
fluid.
the oral intake is not adequate to replace the current loss. That's why probably we worried more on the second case, the first case than the second case. Susahnya dalam medicine tu tak boleh fikir banyak Muslihana, what the essence of the second case?
Steroid resistant nephrotic syndrome.
Steroid syndrome, kenapa dia datang ke ward? Siti Noh.
For the first case,
Talking about second case. Asking you.
huh?
Asking you the second case, the essence of the second case.
Oh, second case. The child come with progressive worsening or generalized body swelling.
Neuroinis. What the essence of second case? Satu sentence. Satu sentence consists of 7 to 8 words only.
Steroid, 6-year-old Malay girl with steroid-resistant nephrotic syndrome, with generalized body swelling.
Dah lawa lah the first 5 sentence tu. At the end tu dia terus haywire terus. Out terus. First sentence tu okey dah. Tiba-tiba masih lagi tak dapat. Aina?
Amni 6 years old with underlying steroid resistant nephrotic syndrome presented due to worsening generalized body swelling.
Sama je. Apa beza je sekarang tu dengan Anis punya? Tak boleh sophisticated sikit. Tak boleh you go nampak dia punya problem dia. What the cause of generalized edema ni?
From the history, there is a provocative factor like infections.
Answer the question. What the cause of generalized edema?
Fluid loss.
Protein.
Fluid loss to the third space.
Pardon?
Fluid loss to the third space.
What the cause of generalized edema in the second case? Anybody?
Increased permeability of the glomerulus causes of extracellular fluid shift.
Doesn't matter lah, dia pathophysiology. What the causes is what?
Increased permeability of the glomerulus.
Apa the causes? What is the cause?
Hypoalbuminemia.
Yes, all these things, what we call that?
Relapse.
What the child having now? What's the child having now? Relapse. So what's the essence of this case?
Multiple history of admission.
Dan dah Anis dengan tu dah buat dah tadi. The first 5 words is dah okay sampai the last 3 words tu.
So Amni, 6-year-old Malay girl with underlying steroid-resistant nephrotic syndrome presented to HTA due to relapse of nephrotic syndrome with fluid overload.
Tambah lagi. Tu dialog dah tu dia tu. Tambah lagi belakang 3 ayat tu. Terus KO balik.
Sampai nephrotic syndrome dia.
Dah okey dah. Dah habis dah. Tu tambah lagi 3 ayat yang terakhir tu. Kenapa mesti ada ayat yang terakhir tu?
Silap lah tu, sorry.
Cuba lagi Ayana.
So, Amni, 6-year-old Malay girl with underlying steroid-resistant nephrotic syndrome presented to HTAA due to relapse nephrotic syndrome.
Susah sangat. This is a 6-year-old girl, nephrotic child who having relapse. Tu je. So next question come to you apa benda? What is the next question come to you? You know, I trying to make medical easy. Ada buku kan, medical, make life medical easy for the ni. So what the next thing come to you?
Why is the patient having relapse?
Yes, why the patient having relapse? The next thing come to you. So what's the possible causes of relapse?
Due to infection.
Apa infection ya? You know infection tu orang layman. For your level, beritahu lah apa benda infection tu.
Or maybe non-compliance to the medication.
Non-compliant lagi.
Upper respiratory tract infection.
URTI lagi. Itulah sayangnya lah. Where you can get the cause of relapse, list of cause of relapse. Where you can get? Where you can get? Cause of relapse. Where you can get the list? Where? Anybody? If you don't know the cause of relapse, where you can get the cause of relapse? Information about cause of relapse. Anybody where? Where you want to check?
Probably try to search in article.
Search in?
Article.
Where the article is?
Internet. From internet.
Internet lagi? Apa?
From textbooks.
Books, journal. Kalau you tak tahu, you just type lah. Cause of relapse in nephrotic syndrome, children. So type. Relapse, cause relapse, nephrotic, nephrotic. Apa keluar? Susahnya alhamdulillah medicine ni you all ni. Kenapa ni susah sangat medical ni dengan you all ni? Apa tulis?
Acute respiratory infection as well as urinary tract infections. the most frequent in fact
Lagi
to
apa
hear.
lagi poor compliance,
Yes.
inadequate medication, dose salah, lagi disease become more severe. Ya. Kan? So did the history answer all those things? History presented, did they answer all those things? The causes of relapse? Ada?
Yes. Yes. She did mention about the patient have an respiratory tract infection.
Okay. Ada the patient having UTI, compliant.
For UTI, she already said that there is no UTI symptom like pain during iteration, no
Okay,
hematuria,
lagi?
and incontinence.
Compliant. Ada the answer all those things. Okay, the next thing, chronic cases. You know that chronic cases ni they going to, you know kan, chronic cases. What is the problem in chronic cases? The effect of the disease and effect of the medication. Did she mention the effect of the medication? What are the effect of medication in this case?
Pushing syndrome.
Steroid toxicity.
Okay, she's still on steroid, a lot of steroid. Is the patient still on steroid a lot?
She stopped taking steroid 2 months before she comes from 2 months prior to the presented complaint.
But then she's used a lot of steroid, is it? Despite of the.
Yeah, yes.
So any evidence steroid toxicity in this child? From the history. What steroid toxicity you're talking about?
Such as cushion features, moon face, buffalo hump, stripe, acanthosis nigricans.
Pardon?
Acanthosis nigricans.
Apa?
Acanthosis nigricans.
Lagi?
Truncal obesity. Yes. But she is 6 years old, maybe no signs of acne.
Acne, wait until acne, betul 6 years old dapat acne kalau dose on steroid.
The other thing would be cataract, short stature, hyperglycemia, or hypertension.
So did the patient has all those symptoms of short toxicity? Ada? Ada ke tak ada? You mention or you don't mention?
I didn't mention in the history.
The mention had change complaint of vision decrease, complaint of polyuria, polydipsia, complaint of easy bruises, complaint of where you going to get all the info to short toxicity?
During physical examination.
Where you can get all the list of the info on short toxicity?
Also.
Pardon?
From the book.
You cari tak sebelum you present?
Cari.
Cari. Kenapa you perasan dia tak ada dalam history? You tak try to inform us that Bernie kata, I think the history is not complete because he didn't tell us the sign and symptom of stroke toxicity. You tak berani nak beritahu macam tu?
Sorry, because I clocked this patient 2 years ago, and during
You
that
clocked
time,
2 years ago. Then you katalah, I'm very sorry, I clocked this case 2 years ago. Now I cannot see the patient again, but I realized that in my clocking, there are some deficiency in my clocking in which I am unable to elicit the stroke toxicity in this case. That I expect the child will have some stroke toxicity because the history of prolonged use of steroid. You tahu tak, I going to be impressed. You say that, wow, very good this fella. She really, she looked the history and she really, wow, she really knows that there is something is not complete in the history, and you will always remember it for the rest of your life. Betul tak?
yes.
You remember, you always remember. You got case on steroid, long steroid, then automatically you know what to ask. So I will interested to know dia punya ni weight dia punya height compare to school, ada dia pendek sekali dalam kelas. I want to know how it affect the social, dia punya social, betul? Ni all those things. Because this patient has life. Jangan sedih pula. Tapi that's waiting for that. Okay, what's the thing you look at in this chronic disease? The complication of the disease. Is there any complication of the disease mentioned in this case? What the complication of disease you expected in this kind of case?
Primary peritonitis.
Lagi?
Thrombosis.
Lagi?
Hypovolemia.
Hypovolemia, they have some evidence hypovolemia, but the rest, the other?
There be some of acute renal failure.
Acute renal failure. Did the child have all those things? From history. You can see there's no history of peritonitis, or which is child having abdominal pain with fever. There's no history of pain at the calf. The child is the last liver, the last renal profile was done, doesn't indicate the child is having renal failure. Best you nak goreng. Kan? Sedapnya, I dengar pun sedap. Wah, bestnya budak ni goreng. You see, history can tell you without we going into physical examination, history can give you a lot of information already. Children, why is it in children we are particular about the history? Because it's not easy to do the physical examination in children. 6 years old pun boleh grumpy juga, you kan tak tahu. So you are because sometimes we are very dependent on the history and observation to make a decision. That's challenge about PITS. Sebab tu orang PITS ni dia banyak cakap, dia banyak komplain, dia banyak beletih. Because dia tak boleh depend pada physical examination sangat. That's why in pediatric, history has to be precise. You tengok banyak-banyak fraternity yang banyak fraternity yang complain pasal history speaks. Because we are very dependent on history. 2 years old. Examine, senang examine budak 2 years old. It's not easy. But there are many patients that range. When the child is ill, they are very grumpy. They don't want anybody to examine. They don't want anybody to come near to them. They're very grumpy. You nak pegang tangan pun tak boleh. Dah melalak dah. So you're very dependent on the history. Okay, the first case. What's the extent of the first case? Siapa dia? Somington. Siapa nak volunteer? Haikal.
2-year-old Malay boy presented with vomiting and loose stool for 3 days. it is associated with fever and abdominal pain.
Satu sentence je. Haisnah. Hana.
Yes. The 2-year-old patient presented with vomiting and loose stool for 3 days duration with complication of
Terus ni. Okey dah mula-mula. Amirul?
Amiruddin, 2 years old Malay boy, presented due to moderate gastritis.
Siti Aisyah.
Two years Malay boy presented with history of vomiting and diarrhea for 2 days duration.
Dah lah. Finish lah. So what the next thing come to your mind?
Find the cause.
Apa?
The cause of infection.
Dah okey dah. Cause, dah okey dah tiba. Last word tu KO. Nurul lah. What is the, the investigative mind punya ni? This is a 2 years old boy who's having diarrhea or vomiting.
I would like to do renal profile to assess
Ada ask you, what is the essence? Ada ask you on the profile.
To Amiruddin, 2 years Malay boy presented with loose stool, vomiting and fever for 3 days with moderate signs of moderate dehydration.
This is a Nurul Anis. This is a 2 years old boy who having diarrhea and vomiting. What the thing come? What the issue? What is the thing come to your mind?
The complications of the symptom.
Next, Musliha. Apa susah nak fikir?
Suggestive of acute gastroenteritis.
Aliana.
Severity.
You are a doctor. You want to solve the patient problems. This is patient who are coming with vomiting and diarrhea for 2 days. What the investigation issue come to you? Start with W.
weight loss.
Siti.
I don't know, sorry.
Aina. Aina muka tension je. Tension. Dia tadi gesah ya. You down to your mind. What you want to know is what the cause of diarrhea and vomiting in this case.
We took white blood cell.
You understand or not? Tak dapat lagi. This is the case 2 years old boy who's having diarrhea and vomiting. Your investigative line is to find out what the cause of diarrhea and vomiting in this case. Itu je. But in order for you to know the cause of diarrhea and vomiting in this case, what the percept that you have to have in your mind dulu, and brain you all. If you want to tackle this problem, you want to answer the problem in this child who having diarrhea or vomiting, what's the thing that have to come to your mind? Yang mesti ada dalam otak you. You have to have the list of the list of the cause diarrhea.
Probably due to viral cause.
Susahnya. You dengar, listen carefully. In order for you to answer the causes of diarrhea and vomiting in this case, you have to have inside your brain a knowledge of causes or the list of the causes of diarrhea and vomiting. So can you tell me the causes of diarrhea and vomiting?
Infectious causal.
You fine, doktor. Cukuplah pakai nama infectious causes tu. Ini doktor pakai infectious causes lagi. You kan year 3. Boleh tak dulu cakap tu mulut tu fikir dahulu. You know infectious causes tu apa? Cellulitis. Otitis media. Think dulu sebelum you cakap. What the causes of diarrhea or vomiting that you know? Apa dia? Tak tahu causes diarrhea or vomiting.
Enteral and parenteral? No.
We're talking about causes. You tell the list of the causes tau. If you don't know, what you do? You go and search the list of the causes. Where you find the list of the causes? Google lah. Tak Google pun you boleh buka buku. Kalau you don't know, you find it. A minute you are not prepared, tak boleh jadi doktor lagi. Even the basic thing, the causes of diarrhea vomiting pun you tak tahu, tak boleh list out. Budak third year boleh kasih AGE, food poisoning, lactose intolerance, you all tak dapat. Third year boleh tak like that. Basic things. Kau punya protein itu CMA, the third year boleh answer. Apa dalam you Google apa yang keluar? Apa? Because you all tak boleh nak like that. You see, we are not going to teach you all these things. You tahu tak? You have to read yourself about EGE. You have to read yourself about the food poisoning. You have to read yourself about the cosmic protein intolerance. You have to read yourself lactose intolerance. You have to read yourself all the other causes. My job is to teach you all how to think. That's all. Because everything now is a tip with the finger. The knowledge. You buka saya internet, you buka dalam buku atau internet sekarang ada internet. Dia tulis ya causes of diarrhea and vomiting to in children. Dia keluar dah panjang keluar loss causes dia. Ada. Siapa present this case tadi? Siapa present tadi? Husain.
Me, doktor.
Siapa? Tak.
Me. Nuranis.
Then what the causes? But right before you present, you list down to me the causes.
For diarrhea, there is two, it can be classified into two, whether infective or non-infective.
You know that is your thinking inside you. But when you tell us, when we ask you the causes, we want the possible diagnosis. You know, I can mention to you AGE ni semua tau. I expected you the same thing. No, the back of the causes you work up inside your brain. You tell us when we ask you the causes, we don't ask you how you divide the causes of the cost. If we ask that questions, then you answer into that. But I asking you the causes. The causes mean that you have to tell us the possible diagnosis. And then I expect you all, before you present this case, you already make your homework already. Because definitely I'm going to ask you the causes of diarrhea vomiting. And then when you come to me, you can list down. Tak. Oh, I'm going to impress. Saya cakap, budak ni dah prepare. It's, discussion is very nice. We can go discussion. And you can go to higher and higher and higher level. You understand? There are other higher level of discussion than this. But it depends on your basic knowledge dahulu. Oh, if you are unable to give me the basic knowledge, then how are we going to go higher and higher discussion? Because you, at the moment, I'm going to ask you, okay, you think this patient, how you differentiate this patient, probably food poisoning or AGE from the history. Tapi if you cannot tell me the causes, how are we going to higher than that? How you going to, what is this case? How, for this case, you think this is latest intolerance or this child is having acute AGE? Tu belum lagi kita pergi discuss AGE lagi detail. Is it viral cause? Is it this is it yang berat berdarah betul due to rotavirus ke ni, what the typical stool of rotavirus, all those, we don't go yet that level tau. We still give you the causes and then how severe dehydration status, tak pergi tinggi lagi. So what the causes? Anybody?
Can be urinary tract infections, food poisoning, and it could be otitis media or pneumonia can also cause.
I ask you one thing. In betul, if in datang dalam kes dalam tu in the apa tu in apa MCQ, causes of diarrhea, otitis media, true or false? True or false? You see, in medicine, if you think everything is possible. Semua boleh jadi true. Everything is possible. But when we're talking about the ni, we must in cause and effect. You have to be clear on that. So what you think in otitis media, true or false? Causes of diarrhea: A, AGE; B, otitis media; C, UTI; D, food poisoning. Semua true. Semua true. You answer semua true, jawapan you 0. Kosong. 0. 2 salah, 2 betul. Tapi you duduk lama-lama, you fikir. Kalau you fikir sekali lalu, which one true, which one false? Sekali lalu.
AGE and food poisoning is true. And the other two is false. AGE and food poisoning is true, and otitis media and UTI is false.
If you fikir sekali lalu, kalau you fikir lagi, you go sekali lagi, you duduk situ termenung, you fikir, everything will become true. Fikir betul become true. This is dangerous kalau you buat MCQ, you fikir banyak sangat. I think the reason why you are difficulty MCQ because many time you fikir dalam sangat. You fikir dalam sangat. You found out on many instances what you think the first thing thought usually is correct. Commission very dangerous. You think too deep because everything can become true. So nothing is impossible. Siapa buka internet tengok apa courses saudara? Tak ada. Tak ada, we stop here lah. Cannot go further. Because you see the point I want to put up to you is that first I want to make show to you the thinking of medicine clinical simple sebenarnya. The step of thinking is simple. It just matter you think as a investigative thinking. It becomes difficult because you thinking so banyak sangat. The process of thinking is to answer why, where, what. The second thing is that where you want to put your reading inside the clinical thinking. Your reading is to answer the patient problem. This patient problem is diarrhea vomiting. This patient, you need to solve the patient problem. Before you solve the patient problem, the causes, you must have the basic knowledge first. The basic knowledge is come from your reading, from your internet, reading internet ke book, and the where you put it is when you have a problem to solve. Your problem is this patient have diarrhea vomiting, acute, and in between, and you have your knowledge of acute diarrhea vomiting. Your brain the facilitate to go through list down the cause of diarrhea vomiting. When you list down at the same time all the characteristic of diarrhea vomiting, each disease already come to you. Then when you clerk your patient, you already have everything at your fingertip. That's why you found out some people can clerk half an hour, some people can clerk 15 minutes, they can solve the problem. Some people clerk half an hour pun unable to solve the problem because they are unable to organize their thinking, and unable to organize their thinking, then unable to organize their questions. They answer semua, but hoping that they hit the jackpot. But if you organize your thinking, where you ask the questions, you know already what to ask, and you can from there you get the answer already. But 15 minutes you already know what's the problem, what the answer for your problem, patient problem. I mean that's how what it means by reading around your patient. If you're reading for the exam, then you will get exam. You pass lah for the exam, tapi you cannot remember. I can jamin you. But if you're reading around your patient, no, your patient is your book. I can promise you remember it for a long time. Because you're reading around your patient, because you try to solve your patient problems. Your patient is acute diarrhea vomiting, you sit down, you read, you accumulate the need, then you solve the patient problem. The other people, what they do is that for beginners, sometimes they clerk first, they read, they found out the clerking and they read tak sama, then they go and reclerk balik in order to get what is but some people, if you certain level of you the sophisticated, and when the child coming already with a problem, you already have the set of mind thinking list inside your brain, then you clerk your case, you already bypass certain, and then you enjoy medicine. You get the gist, they call the gist of the medicine. Then you wonder why some people enjoy the medicine, some people didn't enjoy the medicine, because some people get the gist, they understand, they're able to diffuse their knowledge with the clinical, and they enjoy it. Any questions? Susah medicine ni, fikir. Is it tough? Simple lah. Everything in medicine, I found out the most difficult to teach you all. Itu apa benda? Something that I found out to teach you all. Common sense. Thinking in common sense. Thinking step by step. You banyak bypass, terus fikir complication, terus fikir. Step by step, identify the problems. What is the issue? What's the disease? What the cause? In medicine banyak W. You tahu W? You tahu W tu apa? What, where, when. It's W. What, where, when, why. Mungkin orang cakap, wah paranoid je dah tahu ni. Tapi that's how we are. We are investigator. Basically. We are not just we are basic investigator to solve the patient problem. Okay, any question? Ada question tak?
No, so far.
No.
Ada? Anis, ada question? Tak ada? Aina? Still unable to enjoy medicine. Dah enjoy dah? You nak hidup, you nak habis dah? Next year you dah going to become our colleague. Once you got the R depan tu, you are our colleague. Tak sabar jadi my colleague. You become my colleague dah. Once you got the R in front, you are my colleague. Berapa lama lagi? 1 year, tak sampai 1 year lagi. Tak bolehlah nak marah macam ni. Tak boleh. Because you already my colleague. Itu my colleague, artinya you are ni equal dah. Boleh? Any questions?
Doctor, I like to ask.
Yeah.
As we know, the nephrotic syndrome, the patient has a prothrombic state. I do read somewhere that a patient who has nephrotic syndrome can have a seizure in the ward. Is it possible because due to the cerebral venous sinus thrombosis? Like it is a common case in our sector.
I've not very rare. It's not very. They can have renal thrombosis, but renal thrombosis more at the calf muscles, below limb. Rarely they can have because they have upper coagulopathy. They have upper coagulopathy which can occur anywhere, but then it's very rare they have to in the brain there. It's not a common thing.
So we usually ask only about the calf pain.
Pardon?
So usually we just ask the patient about the calf pain.
Yeah, usually the pain, thromboembolism is more of calf pains, tight pains, all those things. More the calf lah.
Okay, doctor.
The one that I saw, all them is calf muscles. I've not seen the one beyond that. Not many. 1 case, 2 case only. Total cell bar case. The rest I've not seen. And because we are very aggressive now, we are not going to use penicillin. We use, but there are other medication now we have, not only penicillin. Very aggressive. So we have many other drugs. New drugs are coming in. Then many of them responsive to the drugs. Okay. Any other questions? Okay, finish. So ada hutang you all anything tak? Apa-apa tak? Tak ada Do I have assessment of development dengan you all? Bukan kan? Dari group kan? Who want to do, who did the assessment development dengan you all?
Dr. Sheikh.
Syed. Sheikh. You panggil dia Sheikh ya? Nanti beritahu dia, doktor anak buah you panggil you Sheikh. Oh, dahsyat, Sheikh tu. Naik pangkat dah dia. Dia dah ajar belum? Dia betul dia tak dapat ajar lagi. Dah ajar dah? Belum. So kita mesti lagi we have not yet decided how to teach you all developmental assessment because of we really big difficulty how to teach you all developmental assessment without patient. Now, how are we going to teach you all developmental assessment without patient? Because developmental assessment has to be taught with patient. So we need time to think about it. Hopefully, if you come back, then we can teach you all. If not, we have to find a way to teach you all how boleh kita buat satu baby depan you all. We don't know, right? Because WhatsApp ni limited kan, dia punya vision ni kan. How far WhatsApp pun you all boleh nampak berapa jauh you all boleh nampak. Tak jauh sangat kan, limited kan. Even if kalau buat share screen pun tak jauh sangat kan. WhatsApp. We think about it. We be a trial. Tengoklah. Kata ada, if you do it face to face, we do a trial. Tengok. Because I don't know. We think how. I think the development assessment is the problem. The theory part not a problem. And then the clinical bedside teaching, well, you have your opportunity during third year, and then probably by middle of next year, the latest of the vaccine will be middle next year. Middle next year. I don't know when you're going to be vaccinated. I don't know, medical student is high on the list or low on the list. I tak tahu. Are you frontliner? You're frontliner tak? Tak. But you're considered as high risk juga kan? You're still young kan? Young. Tapi tengok macam mana. Because it affect the teaching. Mungkin kita boleh argue the teaching you need to have exposure for teaching. The problem, the decision maker is a politician, not us. If we doctor decision maker, then we will, because you are going to become our colleague, we will make you one or two in front will be vaccinate. Politician probably the last one. Tak perlu nak vaccinate politician cepat-cepat sangat ni. See how it goes. Okay. Okay. Tak ada apa lagi finish. Okay
Okay, thank you.
Thank you, Doktor.
Last kali nanti WhatsApp. Berapa markah nak beri? Okay lah. So, siapa present tadi? Ya, Anis dengan?
Saya. Siti.
Mana Siti? Dapat 77.
Thank you, Doktor.
Tak cukup? Nak tinggi lagi?
8 tu okey.
Berapa? 6, 7, 8?
Ikut Doktor.
Ya, 9, 10 pun boleh. You nak 11 boleh beri. 11 boleh. Okey Okay.